So my name is Rob Blum, and I'm the Clinical Director of Cancer Services at Bendigo Health. And I'm also on the governance group for the Loddon Mallee Integrated Cancer Services meeting. And I'd like to welcome everybody today for the Loddon Mallee Integrated Cancer Services Annual Forum. Before proceeding any further, I'd like to make acknowledgement of country. I begin today by acknowledging the traditional custodians of the Sharjah Wurrung land on which we meet today and pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander people here today. So thanks to all the LMICS member organisations, other stakeholders and interested people for joining us to learn more about the important topic of skin cancers in our Loddon Mallee region. So LMICS's role is about cancer service improvement, working collaboratively with hospitals and other services to improve access and appropriate care for patients with cancer. Today, we will not only hear about an exciting 2-year region-wide skin cancer project that LMICS will be coordinating, but also about some of the great works in cancer promotion and clinical practice that is already happening. We're going to hear from 3 speakers today. Alex Cameron, who is a plastic surgeon who has a particular interest in skin cancer. We've got Dr. Sam Harris, who's a medical oncologist, again, who has a particular interest in management of metastatic skin cancers, as well as early skin cancers. And we've got Sharon Jones from CCB as well, who has a particular role in promotion. So importantly, we will also hear from a patient and a partner about their lived experience with skin cancer and their experience here in the region. In terms of the proceeding of the meetings, we have a chat function which is actually available throughout all the sessions. So if you have any particular comments or questions that you wish to raise, it will then be acknowledged by the team that are looking after today's meeting, and certainly the questions can be read out during the session at the end when questions will be answered. I'd like to formally thank the LMICS team for making today happen, and for all the contributors, and I'm sure that you'll enjoy today's session with lots of information and excitement about the work that's being done. I think it's really important to stress that the LMICS has a very regional approach. Okay, so we're really looking at ensuring that we're working in partnership with people from all the region and addressing sort of the potential deficiencies to improve the outcome for our patients. Okay, so Cheryl is now going to basically take over in introducing our next speakers, and so she's the manager of the Loddon Mallee Integrated Cancer Services.
Thanks, Rob, and good afternoon to everybody. And I'd like to extend my welcome and thank you for coming to the LMICS Forum. Like Rob says, today has got a focus on skin cancer, both the clinical and the preventative aspects. And as the manager of the LMICS team, I would like to just run through why we are so passionate about skin cancer and what we intend to be doing over the next couple of years, particularly in this topic. I do just have to say it is a little bit weird when you're running online forums. I'm sitting in a room staring at other people and you're at home on your screen, and it's just a little bit discombobulating. But I hope that you can all see and hear. And if you have any technical issues, if you could put in the chat so that we can address those. Okay, so I'm sure we all have memories of, for those of us that have got a few years up our sleeves, we have memories of what it was like as kids in the sun, whether it was going to the local swimming pool and getting cold and then lying on the concrete because it was the only warm place. And of course, we didn't have sunscreen back in the day. We had baby oil maybe that we used to smother on ourselves. I even heard a dermatologist recently quoting his sisters used to put elf oil on top of the carport and lie up there to try and enhance their tan. He was obviously quite concerned about that later on in life. So we know that the sun has been a big part of our socialisation, particularly in this region. I can recall as a kid growing up in central Victoria, going to sleep on a lilo at Kangaroo Lake and having a really serious sunburn. And that's not an unusual story. But what we realise is that it's caught up with us because of the cumulative exposure to the sun and the ramifications that that has for skin cancer. Fortunately, as a public health issue, Cancer Council Victoria have been addressing this for some time, and we know that the slip campaign in the 80s made a big deal. But unfortunately, melanoma is still one of the top 5 cancers in Victoria and certainly in our region. There is less data on non-melanoma cancers like BCCs and SCCs, but we know that that puts a big burden on those in the primary care sector, particularly GPs that are treating those. And also the seriousness of these cancers cannot be underestimated, and we'll hear about that from a patient later on. So the exciting thing is that skin cancer is one of the most preventable. Oh, I seem to have Alex Cameron's slides now. No, I don't. Okay. Skin cancer is one of the most preventable cancers. And for those of us that work in cancer services, sometimes it does feel a bit of a lottery ticket when we see people in the waiting room that look like you and I in terms of, you know, how people develop cancer. And there's often preventable factors, but we also know that sometimes there are, whatever it is, the powers of the universe that just work against. But with skin cancer, what is exciting is that there are preventable aspects of skin cancer. So why is LMICS involved in skin cancer? Next slide, thanks. So if there's nothing else you remember from today, all you need to remember is that I've said 3 things. 1, we know there's a problem in our region. 2, we have got a lot of incredibly skilled, passionate people that work in the skin cancer space in our region, some of whom you'll hear from today. And 3, there is change potential. And so that's the exciting thing that I just want you to take home. So, but if we can just look at a couple of key reasons. So incidence, we know that particularly for men in our Loddon Mallee region, there is a higher incidence of melanoma. We know that the risk factors are greater. You've only got to drive through our Loddon Mallee region and realise that we are a very hot part of the state. We don't have a lot of shade. We have a lot of occupations that involve exposure to the sun. The demographics mean that we have 60% of our population actually living in small towns. That has implications for access to health services. There is a maldistribution of skin cancer specialists. It's virtually impossible to see a dermatologist as a public patient, even as a private patient. And we know that the distribution of plastic and general surgeons for skin cancer work is also right. I need to speak faster, I've been told. GP workforce issues, travel and transport will speed along, community understanding of the seriousness of skin cancer, the actual complexity of the disease, and also the huge cost to the health system. So what are we going to do? LMICS has spent the last 6 months after a project was endorsed by our governance group to actually scope a 2-year intersectoral population health project on skin cancer. Clearly, this is not something we want or can do on our own. We've formed formal partnerships with the Murray Primary Health Network, the La Trobe University and the Bendigo Cancer Centre. And during that scoping time, we've actually consulted with over 20 other organisations and key services to make sure that the skin cancer project that we have planned is actually realistic, that's achievable, and that it's connecting with other important work that's being done. So the objectives there are around raising the awareness, particularly focused on the optimal care pathways around timely and appropriate care, really engaging from a collective impact perspective with others to come up with solutions that are collaborative and realistic, and also to advocate for how we're going to implement these improvements. Next slide. So in the first year, we'll be doing an environmental scan. Pretty much the 4 key things we're doing is we're engaging with people. We are looking at data. There's a lot of important data we need to know about incidence, prevalence, demographics, referral pathways for patients. We need to map what is currently going on before we can identify where the gaps are. There's some fantastic work going on in our region. We need to capture the strength as well as the challenges. And then we need to actually identify those. And we will also be trialling some particular ways of better supporting GPs in the fantastic work that they currently do, but how we can strengthen and support GPs, particularly around the excisions that they do within their scope of practice. By year 2, we hope to have collated that information. We'll be setting up advisory groups and governance groups for this project, and that we will generate some reports that actually identify the opportunities and the recommendations for how we can work better together. We obviously, LMICS don't have endless buckets of money, so we're not saying we will be able to fund all these initiatives, but we are going to be advocating and working with others in the sector to work out what is realistic and to try and lobby and secure appropriate funding for interventions. Sometimes they're not new things. Sometimes it's a matter of connections, linking, doing more of something else that we're doing in one part of the region in another part of the region. And we will also produce a feasibility study report on the work that we're going to do in the excisions space. So lastly, the last slide is looking to the future. Yes, it is an ambitious and a bold project, but we need to connect back to the why. Why are we doing this? We're doing it to improve the outcomes for patients. We're doing it to have a focus on localised solutions and to support the amazing clinical team that are already in this space, and to remind ourselves that it is one of the most preventable cancers and that we can protect the health of the future if we all work together today. So thank you so much, and I'd like to introduce Shannon Jones, our next presenter. Shannon is from the Council of Victoria, and she's the Manager of Health Promotion and Allied Health. And we've worked with Shannon and CCV over the last few years around increasing dermoscopy training in our region and a range of other programs, and we're really thankful for her contribution. Shannon will be coming to us remotely. Thank you.
Thanks so much, Cheryl. Could I just get a thumbs up from someone in the room that you can hear me okay before I get started?
Can I see them? Yes.
Okay, just give me 1 minute. I'm just trying to share my sound.
Shannon, we can hear you well.
Great, thank you. I'm just trying to share my sound, sorry.
We need to...
do you happen to have the presentation loaded up on your end, Cheryl?
Yes, we do.
It's just not letting me share the sound.
Just have to chat to me for a little bit longer. So we do have Shannon's presentation loaded, and Shannon, we can actually hear you. I'm not sure whether you can hear us, but we're right to go from this end.
Great, thank you. I'll get you to share it from your end. That would be fantastic.
So we're doing that now.
Thank you. Technology is amazing. I will kick off while the technology is sorting itself out. So thank you for having me. Good afternoon, everyone. My name is Shannon. I, as Cheryl said, work within the SunSmart program, which is a program of Cancer Council Victoria. So the SunSmart program started in the 1980s, where many of you may recall we had Sid the Seagull spruiked across our TV screens with the slip, slop, slap message. And we became a settings-based health promotion program. So we work across a number of settings, including schools and early childhood programs. We work across workplaces where we engage with outdoor workers, and particularly regional outdoor workers, and especially with health professionals, where we know we have over 1 million patient encounters each year for skin cancer in the general practice setting, and many other health professionals that are touch points for skin cancer prevention and early detection. The SunSmart program is also the World Health Organization Collaborative Centre for Skin Cancer, which is something that we've had for some time now. And our impact in preventing skin cancer has been acknowledged as one of the 10 successes of public health in Victoria. So since the inception of the SunSmart program, there's been a decline in melanoma rates in Victorians under 50, that being those who grew up exposed to the SunSmart program. And the SunSmart program is estimated to have prevented more than 43,000 skin cancers since the program's inception in 1988 and 2010, with a net cost saving of $92 million to the public health system in Victoria. So a cost-effective program. And excitingly, today, the Slip, Slop, Slap slogan has been added to the National Film and Sound Archive, along with the How's That by Sherbet. So that's an exciting little add-on for today. When you get the presentation loaded up, if you can just flick to the next slide, that would be wonderful. So Cheryl has mentioned that skin cancer is largely preventable. So about 95% of skin cancers can be prevented by using appropriate sun protection. In Australia, we've got around 2 in 3 Australians that will be diagnosed with skin cancer at some point in their lifetime. So there is a significant burden on the health system associated with that. Australia also has one of the highest rates of skin cancer in the world. But during the COVID pandemic, there was an 18% decline in melanoma diagnosis in 2020 and a 12% decline in 2021, meaning that there are about 827 fewer melanoma diagnoses during that time than expected. Regional Victorians are also 44% more likely to be diagnosed with melanoma than those living in major cities. And overall, melanomas account for about 8% of cancers diagnosed in regional Victoria. Between 2019 and 2023, $4 million was allocated for the development, implementation and evaluation of a new SunSmart mass media campaigns, a series of, in fact, focused on prevention and early detection of skin cancer in high-risk groups, which do include men aged between 40 and 59, outdoor workers and regional and rural Victorians. Next slide, please. So fresh off the press today, we have a brand new campaign which has just been launched this morning. But prior to that, we have SunSmart programs and campaigns that have been in place since the inception of the SunSmart campaign for 30 years. So there's really clear evidence that exposure to SunSmart campaign advertising, which we've had on TV since the 1980s, has a really positive effect on Victorian sun protection behaviours and tanning attitudes. So essentially, whenever we're on air, we see that those behaviours are improved as a result of that. So SunSmart advertising has likely contributed to a decline in melanoma rate of younger age groups who have been exposed to the program and its advertising over the years. So we've been funded by the Department of Health for the development and evaluation of a new prevention campaign. As I mentioned, we had the Honourable Marianne Thomas, who's the Minister for Health, as you know, come to a launch just an hour or so ago. So it's been a busy morning, and launched this campaign for us. So background to the campaign is that a review of population data highlighted several key target groups where sunburn and tanning are still high, and sun protection behaviours are falling behind. So based on this, we decided to return to a broad-based population campaign to ultimately affect change in a greater number of Victorians, including those who are at high risk due to those poor behaviours. The SunSmart campaign has been developed as part of a comprehensive suite of prevention and early detection initiatives to reduce the incidence of mortality in Victoria. So the campaign tagline is "Don't Let Cancer In," and it looks to address complacency and increase sun protection behaviours for Victorians in our target group. excuse me, the campaign will highlight that repeated exposure to the sun's UV radiation can lead to skin cancer, including the deadliest form of skin cancer, melanoma. And we highlight that it can also spread to vital organs. So we highlight that high-risk everyday activities like walking the dog and gardening can contribute to that risk, and reiterating the campaign tagline that when you go out, don't let cancer in. To support sun protection behaviours, we'll be reminding everyone to check the UV index levels before they leave the house, and that whenever the UV index level hits 3, which is the level that's determined to cause skin damage and skin cancer by the World Health Organization, people need to cover up from UV during those times. Excuse me. So we've seen positive progress in skin cancer prevention in Victoria, with a decline in the melanoma rates for people under 50. But there's a generation that has grown up with the SunSmart program, but SunSmart is concerned that some population groups are not always listening to these really important messages, with some of the survey data saying that only 1 in 2 Victorians were using sun protection as part of their daily routine during peak UV periods. So it has gone back to a bit of a hard-hitting campaign. As I said, the campaign is on air and being launched from today. So we'll just play the 30-second ad so that you can all see it. Thank you.
I didn't know that walking the dog could lead to cancer. That spread to my liver.
That things like gardening could lead to cancer in my brain.
If you knew that repeated exposure to the sun's UV radiation can cause skin cancer, including melanoma, which can spread to vital organs, you'd cover up. When you go out, don't let cancer in.
Okay, next slide, please. So look out for the campaign, particularly billboards and digital advertising from today, which is really exciting, and it will be running through the whole of the summer period. So we'll have a burst just before Christmas and then another burst after Christmas that you'll be able to see the campaign. And we'll have a range of supporting assets, including our website, which has been redesigned. So it's got a nice fresh look about it from today. So the sun's UV radiation is the main cause of skin cancer, and the campaign message talks about whenever the UV index level is 3, people encouraged to use 5 forms of sun protection. So not just relying on sunscreen when they go outside, but using a long sleeve clothing, an SPF 50 broad spectrum sunscreen, a broad brimmed hat, some shade and some sunglasses. So you'll note that the campaign, the Slip Slop Slap, has expanded from the seagull days where it was Slip Slop Slap to be seeking shade and sliding on some sunglasses. Next slide, please. I won't go into this in a great deal of detail just because of time, but in Australia, we have no population-based screening program for skin cancer. We also know that skin cancers are identifiable to the naked eye. So encouraging people to be checking their skin is really important, and for people who are high risk to have professional skin checks. We also have people who are at high risk of skin cancer, and they should develop a surveillance plan with their doctor, which may or may not include total body photography. And we also know that dermoscopy, and particularly training in dermoscopy, assists general practitioners to correctly identify people with suspicious lesions. Next slide, please. So for the general population, we talk about people looking out for changes to their skin, being new spots, changes in colour, changes in size, bleeding, changes in shape, and different to others. Next slide, please. People who are at high risk are those that have fair skin, who have a tendency to burn, a high number of unusual moles, light-coloured eyes and hair, lots of freckles, a weakened immune system, any history of skin cancer, a history of sunburns and solarium use, and those people, especially males who are over 50. So for these people, it's suggested that they develop a surveillance plan with their doctor, which might consist of professional skin checks, preventative information, and also skin cancer detection, which may or may not be with total body photography. So things like the ACE-MID trial, which is fantastic, that Dr. Harris will be talking about as well, where people can access high resolution images to be able to monitor changes on their skin moving forward. Next slide, please. So I'm fortunate enough to have worked with the Loddon Mallee ICS around the Dermoscopy for Victorian General Practice program and its rollout in the region. We offer a grant program for Victorian GPs to be able to apply to receive a fully subsidised dermatoscope and training in dermoscopy. The program's been running since 2018, and we've had over 400 places offered, including well over 50 in the Loddon Mallee region. Applications are actually open at the moment, so we're encouraging GPs within your networks to be able to apply. Applications close at the end of November, and it consists of between 30 and 50 hours of training around skin cancer and dermoscopy, and you can apply via the SunSmart website. So I've added in a link and we can send around the details. So next slide, please. Just some resources that we offer for general practice. As I said, our website has been redesigned, but I did just want to flag that we have an accessibility function. If people require translations, that is available on the website. Next slide, please. We also offer 6-hour education options for GPs and other health professionals around the prevention and early detection of skin cancer in general practice. So we have 2 forms of online education that can be accessed and accredited. So we encourage, again, throughout the networks to be able to promote the free online learning that's available. Next slide, please. Okay, that's my presentation. I will leave you with my contact details, so if anyone wants to get in contact after today, they are most welcome to. Also, if they want to order any of the resources for practice, they are welcome to do that as well. Thank you very much for your time.
Thank you, Shannon. That was a really great reminder of the importance of the messaging to the community and also the ways of supporting clinical services for skin cancer. We're going to move on to a presentation by Alex Cameron. Many of you will know Alex. He's the head of plastic surgery at Bendigo and also in private practice. And Alex has been a great champion of the work that LMICS is doing in the skin cancer space. And he actually is in theatre at the moment, and so he's got a remote presentation, which includes a very salient presentation of one of his patients, Andrew, who's from regional Victoria, and his partner, Sarah. So tune in, and I hope you find this segment really enjoyable as well as very informative. Thank you.
Hello, my name's Alex Cameron, plastic surgeon in Bendigo and head of the department at Bendigo Health. I work with Broad and Snell at Sandhurst Plastic Surgery. Thank you for having me today. I'm sorry I can't be there in person. I hope this suffices. Talking about squamous cell cancer, a tricky proposition sometimes, and a very important thing to assess and treat properly. You may have seen, if you've seen me speak before, you may have seen this diagram in relation to non-melanoma skin cancer. I think it's a Hindu proverb of blind men who come across an elephant, and each man examines a different part of the elephant. The one who's examining the leg thinks he's found a tree. The one who's got the trunk thinks he's found a vine. The one who is holding the tusk thinks he's found a tree branch. It's only when all of these men talk to each other and put their experiences together that they realise what they're examining is an elephant. I use this as an analogy for the management of non-melanoma skin cancer. It's a difficult proposition because it's managed across many disciplines, from GP and even nurse practitioner through to dermatologists, through to surgeons of various modalities, and through to medical and radiation oncologists. One thing we don't do very well is coordinate our care and coordinate our particular knowledge bases. And I think that's the way forward for getting the best results in this field. We all know that the burden of non-melanoma skin cancer is increasing, although the data on this is not very good because it's not a notifiable condition. But if we look at the rate of melanoma, which presumably non-melanoma skin cancer corresponds with, we can see that it's increasing. And we also know that importantly, GPs manage at least 50% of this skin cancer, which is a difficult proposition, especially in rural areas where we don't have a great number of readily available resources for referral. And that's something we're working on, along with LMICS. So I guess the emphasis of this talk is when you ask for help with squamous cell cancer. The majority of these are low-risk lesions with no real risk to life. However, a small but significant number of them are. Generally, the pathogenesis begins with sun damage or solar keratoses. A certain number of these progress through to squamous cell cancer in situ or Bowen's disease, and then a certain number of these will turn into squamous cell cancer. This is probably the key slide in this presentation to identify high-risk squamous cell cancers. Some of these things can be clinical observations, so a rapidly growing large tumour on on certain anatomical locations, the lip, the ear, and the nose. Anything like that should raise your concerns for a high-risk SCC. A lot of the other parameters are then histological, which you'll gain after doing a biopsy or an initial excision. So anything that's involving muscle or bone greater than 6 millimeters thickness, if it's a recurrent lesion, if it's poorly differentiated, if it has perineural invasion or lymphovascular invasion, if it has in-transit metastases or nodal involvement. So these should be used not only as parameters of which you should judge whether you need to refer. They are also parameters that we use to judge whether the patient needs adjuvant therapy, in this case radiotherapy, as indicated in that highlighted point there. So there'll probably be someone speaking about radiotherapy in this presentation. These are radiosensitive tumours. I don't think there is any role for primary radiation of squamous cell cancers except in very, very exceptional circumstances. And these circumstances probably should be ones dictated by ourselves or within the hospital. Radiation is a very useful modality as an adjuvant therapy after excising a high-risk lesion. The reasons why I'd be hesitant to recommend radiotherapy as a primary modality are, firstly, that we never get a tissue confirmation of adequate treatment. And secondly, if recurrence does occur, this is usually a very aggressive subtype, and the tumour bed and surrounding tissue has been irradiated, so the resection is made more difficult. Immunotherapy will be a game changer in this area. It already is to an extent. Cemiplimab is a immune checkpoint inhibitor of PD-1, and it's been already used in Australia and in Bendigo for inoperable tumours, and some of the results are quite spectacular, and someone will probably be speaking to you about this today. One of the things we've instituted at Bendigo Health is a high-risk clinic So as well as having high-risk lesions, we have high-risk patients. The particular patients at this clinic will accept are those that are immunosuppressed, so transplant patients on immunosuppression or otherwise immunosuppressed patients, and also patients with a predilection for multiple non-melanoma skin cancers or high-risk skin cancers. So with those parameters there, these patients can be seen long-term by this clinic with the dermatologist we have there, and then kept in the system and operated and sent across to us for surgery when required. I provided 3 case studies of sorts to highlight those subgroups of patients in which there is risk for life-threatening or very severe squamous cell cancer. So the first of these is an elderly patient. One of the conundrums, as you well know, with elderly patients getting skin cancers is whether they should have treatment at all. The patients are usually reluctant. The families are usually reluctant, especially so if they're in nursing home care or have dementia. My rule of thumb is if I see these patients and they do have a significant skin cancer, be it SCC or BCC, is usually to try and excise it. The reason being that, as you'll see in the coming slides, these things left for 6 months or a year can turn into an absolute disaster, which is really unpalatable to live with and then to try and palliate. Blood thinners or contraindication to general anaesthetic or anything like that really isn't a contraindication to surgery. There's no real patient in whom skin cancer surgery is contraindicated. It's always just a balance of risk benefit. So those things shouldn't stand in the way of treating these lesions, and we'd much rather treat something when it's small and can be done under local anaesthetic than having to do the horrendoplasties that you'll see in a sec. Healthcare averse patients, occasionally you'll get patients walk in the door after not having seen a doctor for decades. There's nothing really much we can do about these. And then the third case that I'll show is the rare but significant case of aggressive tumour pathology, which despite best efforts causes problems. As I mentioned, GP care is really key to good non-melanoma skin cancer care, and we are very much aware of the difficulties faced in the community and want to provide every avenue to support you. At any time, you're welcome to call me, whether a private or public patient, whether to ask advice or get these people seen sooner if you're concerned. Very cognizant of the waiting times for appointments, the waiting times for surgery in the public hospital, and we're sort of across all of those, but it doesn't make it any more reassuring sometimes for the patient or for yourselves. So any problems like that, please just get in contact and we'll do our best to help in any way. Thanks. Just introduce yourself, guys.
So Andrew Robert Crossman.
And Sarah Crossman.
So Andrew, thanks for taking part in this presentation. We just want to give people a bit of an overview of your journey, so as people call it. So how did you come to get diagnosed with the squamous cell cancer on your nose?
I was sort of self-diagnosed. 2009, had a rough spot on my nose, had a biopsy, and nothing showed up. And then I had a same spot in 2022, around July, and then it settled down, reoccurred in December, went and saw my doctor and said, this is not right. He looked at it and said, yeah, definitely. Took the biopsy and it came back positive. Yeah. And Sarah, did he take much prompting to have to go and get attention?
No, I think just because he's had various skin spots and whatnot on his face over the years, so he's done various creams and burning off and biopsies. So
Yeah.
he's pretty astute to what's going on. So yeah, he knew himself it wasn't right.
And how easy was it to access the GP to get the attention when you needed it?
At that stage, it was reasonably easy. Yeah, it was
And
only
we've
a
got a
few
good
weeks.
we've got a good relationship with our GP.
He then referred you to me.
Yes.
And then, yeah, so how did you, and then we did one procedure to excise the squamous cell cancer. Yeah. At that time, what did you think of the magnitude of the problem? That, did you realise?
Well, I honestly didn't know how serious it was.
Yeah.
I did remember you saying that first operation, we would really like to get the whole thing, because if you have a reoccurrence, it's a lot more complex and difficult. There's more operations involved. So we did get to that point, but it's been a journey.
And then, unfortunately, you were unlucky and you got a recurrence. And how? Tell us how you detected that.
Yeah, well, ironically, it was I was in Darwin at a tennis tournament again, 12 months from when I first diagnosed it, and I got a lump inside my left nostril. Just sort of came up a little bit over a couple of days and got a little bit bigger. So I thought, okay, this is not good. But
yeah,
you could smell it too, couldn't you?
Yeah. And then so back to I think Claire, you actually saw the radiation oncologist.
Yes.
And she could let me know. So then we were faced with a bigger problem. It must have been quite daunting to hear what we were going to do.
Yeah, look, I guess until you come out of the first operation, you realise how big it is.
Yeah.
I mean, you've been verbally told us how big it is, but until you're in that position, you don't really know.
Yeah.
And then it hits you, and the reality is that, it's a big issue, and it's got a lot of healing to do, and yeah, you take it as it is.
Yeah. And now we're nearly at the last, you've had 2 operations, reconstructive wise, on the nose, leaving you with the Mallee grub, or glitching grub, and then 6 weeks of radiation, and now we're about to do the final operation. There might be some down the track. So you've, in this whole thing, you've dealt with obviously your GP, radiation oncology, myself. What have been the difficulties in being based rurally and then having to try and access all these three different specialties?
Yeah, I guess, distance we're used to.
Yeah.
Because we travel for a lot of other things, but look, yeah, it'd be certainly easier if we're in Bendigo, 105 k's Bendigo and back. And I guess from a physical point of view, I was very lucky because I was able to drive myself. I never got to the point I couldn't drive myself.
Yeah.
But medically, I think everything's been pretty good.
Yeah.
Accessing the cells, the Echuca,
I think
Peter Mac and Bendigo is fantastic. So yeah, I think it's. I mean, sure, if there's Peter Mac in Echuca, it would have been a world easier.
Yeah.
But harsh reality, it's not, and it's all economics.
But I think that Echuca being a base for the oncologist and yourself, a couple of appointments has helped, you know, too. So it's, it's a couple less on the road. But the 30 days straight for radiation is biggie, but you battled through, didn't you?
Yeah.
So you just drove back and forth every day.
Yeah.
Yeah.
Yeah. And is there anything in that whole process, from sort of screening, diagnosis, and then coming to access the specialty services, that you think could be improved?
Not really.
No, I think the system worked really well. To be honest, I think it did.
Yeah.
How lucky are we that even at Bendigo, we didn't even have to do Melbourne, people have it a lot worse.
Yeah.
I don't know.
No, you're just grateful that the facilities here in Bendigo, and it's a great facility.
Yeah.
And I think even when we had queries about the nose, we could send photos to yourself and to Peter Mac, and they would answered straight away. So technology allows, that as well.
And how have you guys coped with the stress of it all?
Oh, look, the resilience thing comes into it.
Yeah.
And I think we're both very resilient people.
Yeah.
You know, take it on the chin, deal with it, move forward, stay positive, all that sort of stuff.
Yeah.
You know, not once have I said, why me? I know there's always that tendency to say, why me? Why has this happened? Or get down on yourself. No, it's part of life. You know, I've spent a life in the sun. It's happened. Okay. I'm not ready to go now. I'm going to keep living, but if it gets me, it gets me. But pretty determined it's not going to.
Yeah.
Well, you have been remarkably resilient, and your good humour's been really impressive as well.
I've certainly had a lot of fun with it in public, and you know.
Yeah. Thanks, and I think you're an example of where our systems work well, but a lot of that's down to you guys as well.
Yeah.
All right, perfect. Anything else you'd like to tell the docs, so that the audience will be doctors, nurses, especially?
I think it just, at the end of the day, just can't be understated. You know, the skin cancer thing. There's obviously a lot of people walking around out there that don't know, that unfortunately miss it and going to have a bad ending, unfortunately. Yeah. It's just...
Well, it was. I think that was the thing, sitting in radiation, wasn't it? Yeah. You know, just what you were saying, a lot of, and, you know, I remember the first day I went with Andrew and this girl was sitting there. I said, oh, you know, I overheard it's your father's last day of radiation. That's so wonderful. And she goes, yeah, but he's terminal. She goes, this is the last resort. And I'm like, oh.
And it's even to the point, look, I felt quite young going in there.
Yeah, definitely.
And I physically, you know, feel good. I never at any stage felt like I had cancer. Yeah. I knew I had cancer, and, you know, I know it can kill me. But at the end of the day, this is where the problem lies. If someone's fit and healthy, it's easy to ignore something like that next minute. Yeah, it's too late.
Yeah. Awesome. Thanks, guys.
Well, that was a fantastic presentation by Alex, and we particularly thank Andrew and Sarah for their contribution. I know it was quite clinically intense, and for some of the audience, maybe that's not your perspective in the work that you're doing in skin cancer, but I think they also raised some really pertinent issues around rurality and access to services. Our last speaker is Dr. Sam Harris. Sam's a medical oncologist at Bendigo Regional Cancer Centre, and he has a particular interest in skin cancer and melanoma. And we asked Sam just to do a quick sort of Cook's tour of emerging trends in clinical management. So thank you, Sam. You have to talk as though nobody's here.
No problem. Yeah. Thanks, Cheryl. Good afternoon, everybody. So Sam Harris is my name, one of the medical oncologists. Do I need the microphone or?
No.
Really, I was given a brief, you know, to discuss melanoma in 10 minutes. I think now we're down to 2, so we'll keep going. So next slide, please. When we talk about melanoma, we can sort of talk about it in terms of the stages of melanoma. So early stage, or even before that, preventing melanoma, picking up early detection of melanoma. I just thought I'd highlight one of the programs we have running here with regards to that. That's the ACE-MID trial, which anyone here in this room can get involved in research as a participant. I in fact, have been a participant in this trial. So this is using our 3D. Is there a pointer at all? No, okay. Well, you can see on the left of the screen that the big white machine, and that's a 3D computer camera that takes a full 3D image of the entire body. And you see on the right the pictures that you're getting out of that, and that will using computer algorithms detect any pigmented lesion or suspicious lesion, and look at to see whether it may be a melanoma or an early squamous cell or basal cell carcinoma. The lesions, the program will highlight suspicious lesions. They will then get a closer look with the computerized dermatoscope, and then a dermatologist will have a look at it and highlight any lesions that may need surgery. The patient will then go back to the GP to have those removed. And you can see the bottom right-hand corner, that sort of map of the skin with lots of little pigmented lesions. But they are all the pigmented lesions this patient had taken in. It takes about 30 seconds for the photos to be taken. This patient will then come back in 6 or 12 months' time and have the same photos done again. The computer can then see any changing images over the time, suspicious for melanoma. So we're hopeful that this will be a way that we can pick up melanomas earlier so that they're not needing to come to Alex and me in the future. So next slide, please. In terms of early detection of melanoma, the basics are A, B, C, D, and E. So this is done at the level of general practitioners and to some degree the dermatologists looking for any asymmetry in a pigmented lesion, uneven borders, more than one colour, or a large more than a centimetre in size, and things that are changing in shape. Anything that fits any of those criteria would be suspicious for a melanoma, and we would suggest having them removed. Next slide, please. So management of an early stage melanoma is relatively protocol driven. It's a wide local excision, as you can see down the bottom left-hand corner. The surgeon is getting a decent margin around the pigmented lesion. We're hoping for 1 to 2 centimetres of a margin. That can vary depending on the side of the body. If it's on the face, you're not going to be able to get as big a margin as it is on the lid or the back. So it can involve some reasonable scars afterwards. And then for most patients with melanoma, we would also recommend a sentinel lymph node biopsy, which you may well be familiar with from a breast cancer point of view. It's exactly the same process for melanoma as it is for breast cancer. So on the right-hand side, then you can see that how a sentinel lymph node biopsy is taken. You inject some blue dye, in fact some radioactive dye, at the site of the melanoma. That then tracks through the lymphatics to the lymph node area that is draining that part of the skin. And then usually the 1 or 2 or 3 lymph nodes that take up the most blue and radioactive dye, they what we would call the sentinel lymph node biopsies. So if the melanoma is going to spread from the skin, it would usually go to that melanoma, that lymph node first. And so we'd remove those sentinel lymph nodes. The one difference for breast cancer with melanoma is that if we have a positive sentinel lymph node, then we wouldn't go back and mandate resecting the rest of the lymph node basin. Whereas in breast cancer, we quite frequently do an axillary clearance after a positive sentinel lymph node biopsy. In melanoma, that hasn't been shown to improve outcomes. So for early stage melanoma, early detection, wide excision, and then a sentinel lymph node biopsy to check what's happening in the nodes. Next slide, please. So stage 3, this is when you have lymph node involvement. This is then, so surgery is still the mainstay, so resection of the primary and either resection of the lymph nodes or the sentinel lymph node biopsy. And then they would be referred to a medical oncologist for consideration of adjuvant therapy. And adjuvant therapy has been shown to reduce relapses in about 1/3 of cases. The challenging thing with adjuvant therapy is we never know which patients are going to relapse. As you can see on the slide on the left, if you took 100 patients with melanoma, depending on the stage, but roughly for stage 3 melanoma, about 50% of them would relapse, maybe a bit higher. We don't know which 50 patients are going to relapse. So if we're going to prevent relapse, we need to treat the entire 100 patients to prevent half of those patients from relapsing or 1/3 of those patients from relapsing. So automatically we're over-treating a number of patients. So adjuvant therapy is a challenging thing. Not everybody will get adjuvant therapy. But certainly if you're at high enough risk for relapse, then we would consider some adjuvant therapy, either a year of immunotherapy or a year of targeted therapy to try and prevent the risk of recurrence. The other challenging thing about adjuvant therapy, so this is done after the surgery, is that it's not clear at this point in time whether it improves survival. We know that we can prevent relapses, which is an important outcome in melanoma, and patients hate having their melanoma come back. But our subsequent therapies, if patients get to stage 4, are actually pretty good these days. So if patients do relapse with stage 4 melanoma, we actually can cure them a high percentage of the time. So it's not clear whether patients need to have adjuvant therapy, or you can wait and see whether they relapse or not. But we certainly have a discussion So almost every patient with stage 3 will see a medical oncologist to discuss adjuvant therapy. Next slide, please. Stage 4 melanoma 10 years ago had a horrible prognosis. Median survival was about 6 to 8 months if you had stage 4 melanoma, and we had no treatments that were suitable. Chemotherapy doesn't work for melanoma. So it was with the advent of new types of treatment, immunotherapy and targeted therapy, that we've made real inroads into the management of stage 4 melanoma. And I would consider, and I do consider, stage 4 melanoma to be curative in not every patient, but a sizable portion of the patients. And my treatment is, if the patient is well enough, is aimed at curing the patient of their disease. And both immunotherapy and targeted therapy can be both highly effective treatments. Next slide, please. So I just thought I'd give you some case examples of patients of ours who we've treated over the past few years, just to highlight the inroads we're making. This is a young guy who's 40, who was diagnosed with metastatic melanoma. The PET scan, you can see the black and white on the left, the so-called Dalmatian scan. Every white spot that you can see on that is a metastasis with melanoma. So this patient has literally hundreds of metastases throughout the body. And on the right, you can see that's his brain, and he's got some really bulky and necrotic metastases in the brain. So this is stage 4 D melanoma. Without treatment, prognosis is in the realms of a few months. So, and the picture in the middle are just the colour representations of the PET, just to highlight the extent of the disease throughout the body. So we gave this man doublet immunotherapy. Next slide, please. And within 3 months, he's had a complete response on his PET scan. And this was 2 years ago now, not quite 2 years, almost 2 years ago now. And this patient remains free of disease from his melanoma. Next slide, please. It works in the brain as well. So these are the scans at the top from baseline, the scans down the bottom from at 3 months. And these scans show a near complete response. The subsequent set of scans show a complete response. And again, this man, without any radiotherapy, he had one surgery for the biggest lesion, but only one was resected. But mostly just with immunotherapy, this man, I think, has been cured of his melanoma. We won't know for a few years, but we certainly have patients that we are discharging at 5 years, having had this much disease with no evidence of disease on their scans. Next slide, please. This is another patient of mine who presented with stage 4 melanoma. And you can see on the PET scan, basically on the left-hand slide, all of the red that you can see there is melanoma metastases. And in the two pictures at the bottom are of the liver, and she's probably got 2/3 to 3/4 of the liver replaced by melanoma. And we gave her doublet immunotherapy, and you can see the pictures on the right as a response at 3 months. She's had not quite a complete response, but an excellent partial response. 95% of the melanoma in her liver has disappeared, and most of the disease in her lung has improved as well. And her subsequent images showed an improving response over time. So, we are hopeful this patient's outcome will be excellent as well. And with scans like that 10 years ago, we probably wouldn't have even given chemotherapy. We just would have looked at supportive care. So really highlighting just the massive change in treatment of melanoma that we've received and we've achieved in the past few years. Next slide, please. A final patient. This patient we thought had lung cancer, he had a large mediastinal lung mass. We thought it was a small cell lung cancer, had a biopsy, melanoma. We gave him immunotherapy, and again, the scan on the right, he's had a 15 centimetre mass reduced to nothing in about 3 months. And again, a year and a half down the track, he's still free of disease. So really amazing responses. Next slide, please. This is another example of one of the problems we get with the immunotherapy, particularly with melanoma. It's an idea called pseudoprogression. This is a patient, it's a little bit harder to tell, but on the picture on the left, you can see just in her left inguinal region, just down in the bladder, there's a sort of a white blob there. That's an inguinal metastasis just in the inguinal lymph node. So she had stage 3 melanoma. She didn't want surgery, so we thought we'd give her some immunotherapy. Before starting immunotherapy, she progressed. And on the next scan in April, you can see on her leg, there are all those scattered white spots. They were all in transit metastases scattered throughout her leg, despite a few doses of immunotherapy. So she was clearly not responding to immunotherapy. We pushed on till June, and you can see that clearly the melanoma is getting worse. At this point in time, I told the patient, I don't think this is working. I want to refer you to a clinical trial. And the patient said, I don't want to go to Melbourne. And I said, well, I'm not sure that it's helping you. She goes, I want two more. I just want to try a bit longer. I sort of said, okay, sure, but I don't think it's going to help. And then it just shows you how much I know, because of the next scan, she's had a near complete response. So this is what makes melanoma and immunotherapy challenging. Patients often get a late response. So the immune system isn't like chemotherapy. When you give chemo, you poison cells straight away. When you give immunotherapy, we're relying on the immune system to be stimulated, go out and find the cancer cells and start destroying them. And that can take time, and in this case, it's taken nearly 6 months for a response to be commenced. So when you see our patients and you see them, they seem to be getting worse, but we are pushing on with treatment. It's not because we're crazy, it's not because we're sadist, it's because we think there's a small chance that sometimes things will turn around, but it makes it really challenging. Next slide, please. And this is the same patient. This is some real life photos with their permission. You can see it on the left, the very start, there are a couple of little red nodules around her knee. They were in-transit metastases, but then the middle two, clearly they're all spreading and proliferating in number and size over time. And then the final one, this is not the final photograph, but she's had a significant response. And I saw her the other day and forgot to get a photograph, but next year we'll have the updated photographs, and she's had essentially a complete response in her leg, just to highlight the pseudo progression. Next slide, please. There's no such thing as a free lunch. So melanoma has a risk of side effects, and these tend to be autoimmune side effects. Essentially, any part of the body can be affected. Every patient that I've shown you on that set, except for the last one, spent 1 to 2 weeks in hospital recovering from side effects of their treatment. So there are significant toxicities, and we need to take those into account. But those toxicities, I think, are worth the benefits in the long term. Most of the time, they're reversible, but they frequently require long courses of corticosteroids. Sometimes they can be permanent, such as thyroid failure or pituitary failure or type 1 diabetes or arthritis. And occasionally, they can be life-threatening side effects. Next slide, please. Any part of the body can be affected. Commonly, it's the bowel, the liver, the lung, or the skin or the thyroid, but anything can happen: brain, heart, you name it. Immunotherapy can affect it. So we're always on the lookout for weird and wonderful side effects of patients on immunotherapy. Next slide, please. So just to summarise, immunotherapy, there are 2 different types: single agent and double agent. They're both effective. Double agent is more effective, but a lot more toxic. So we need to judge our patients as their fitness to receive the more challenging regimen. Next slide, please. And just to show you, this is a survival curve. You can see that those curves at the top line there, about 50% of patients are still alive out at not 7 years' time from start with stage 4 melanoma. And those curves are pretty plateau from about the 4-year mark. Those curves don't drop hardly at all. So it tells us that patients aren't relapsing much late if they get that early response. Next slide, please. This is the other type of therapy. About 50% of patients will have a gene mutation in a gene called BRAF, and that allows us to target that gene. It's so-called targeted therapy. And you can see here a PET scan, someone with extensive melanoma. This is a PET scan taken about 2 weeks after they started a drug that targets the BRAF gene, and you can see that all those melanomas have been turned off. The problem with targeted therapy, next slide, is that it only turns them off for a period of time, and then they relapse. This is a patient of mine, September last year, quite extensive melanoma throughout the lung. Started on targeted therapy, wasn't fit enough for immunotherapy, started on targeted therapy, near complete response in 2 months later, felt a whole lot better, was really enjoying quality of life. In January, resistant disease and rapidly progressive, and he died shortly after that. So targeted therapy is very good, but I consider it a palliative therapy. Our first line is immunotherapy. We try and cure patients with that. If that's not effective, then targeted therapy for those that have a BRAF mutation can be a good way of giving them some quality of life and controlling the disease for a period of time, but it's never going to be a cure that immunotherapy is. Next slide, please. And just to show you the difference between immunotherapy and targeted therapy has a high chance of working, but a much higher chance of failing, whereas immunotherapy works for about sort of 50% of patients, and for those patients, they're often, if it's working for them, if they're disease-free at 3 years, I would generally be disease-free at 12 years. And the side effects of immunotherapy can be long-lasting as well as the benefits of it, whereas targeted therapy, it's probably harder treatment when you're on it, but the side effects last, drop away pretty quickly. I think that might be it. I'll make one. Any questions? I on time there, Simon? Cheryl always seems to have too much slides, but I got time. Any questions?
We've probably run out of time for questions, so I might just wrap up, but thank you
No
so
problem.
much.
Pleasure. Thank you.
Yes.
Thanks all.
Thank you so much to Sam. It's very interesting when we look at the combination of the presentations that we had. It's a bit like a jigsaw puzzle, the complexities of the clinical treatment, but also the opportunities and the options for development within this space. And if we go back to Shannon's presentation in terms of the health promotion and the messaging to the community, and if we overlay that with some of the service improvement work that we are hoping to do in the next couple of years, and also just to be mindful that the management of skin cancer is a multi-disciplinary opportunity. It's not just medical treating doctors, it also involves allied health and other people in the health promotion and community development spaces. So we hope that you've enjoyed the Loddon Mallee Integrated Cancer Service Annual Forum with a skin cancer focus today. We do have some questions in the chat that we will follow up via email. And we would like to particularly thank our consumer contributors, Andrew and Sarah, and thank them, and we'll be following up with the presenters to say thanks. And we'd like to thank those of you that are online that have joined us today, and we will stay in touch with you via the LMICS newsletter and our other forms of social media communication that we are developing to keep you updated with our skin cancer project. And of course, we want to acknowledge the funding that we received from the Department of Health to make our service improvement work possible. So thank you and have a great day.